with me today, we have Louis, who is a 40M partner, and we're going to be talking about value-based care, healthcare, technology in healthcare, artificial intelligence, all of these kind of goodies. And we're just going to get started. So, Louis, what's on your mind in terms of healthcare technology?
Well, thank you, Oliver. Very excited to be here and talking about the topics of value-based care and healthcare IT. I think EHRs being the primary vehicle which is used by providers, whether it be in inpatient or outpatient settings, may be a good place to start. And I think when you combine that technology with the new world of post-COVID, one sees that the old EHR paradigm of tying all clinical information or all different types of activities to a scheduled encounter may really be outdated. So one might even say that we should be looking at that paradigm differently, especially with telemedicine and remote patient monitoring.
So you're saying really EMRs, EHRs, they're outdated. I used to call them the glorified billing systems. Really, that's where they come from, right? They come from supporting billing, and it's really a glorified order entry system for doctors, and it oftentimes gets in the way. And really, I think, you bring up interesting questions. So what's the future of EMRs? 40M. What I'm really thinking about, I've worked on 2 EMRs in my lifetime. Build one from scratch and took the other one to the next version, which is crazy on its own if you really think about it. And the pushback I'm getting often from doctors is that it's too hard to use. It's too hard to learn to begin with. And then it constantly gets in the way of a healthy encounter, of a healthy conversation with the patient. And so I really wonder, I'm wondering what's the future of EMRs? And when you look at value-based care, and I know you and I are going to talk about this later a little bit, but when you talk about value-based care and taking on higher risk populations, moving more into population health management, an EMR really can't do this. By default, it just doesn't do this. And it's very much medical or clinical record kind of focused and then claims focused, right?
You are so correct, Oliver. I think that and I've developed EHRs too, one being very prominent in long-term care. And the one thing I learned from that is that in a long-term care facility, there's anywhere from 150 to 300 different interventions that can happen to one single resident on a given day, whether it be giving a medication, turning and positioning, helping with activities of daily living. And then, Oliver, what you said about value-based care, when value-based care is applied, and it may be through population health or other means, there's care coordination that occurs, and not all the time does it end up in a scheduled encounter. It may be a particular intervention. It may be a telemedicine encounter. It may be a coaching event. It may end up in something related to remote patient monitoring. It may be getting an assessment of the patient to determine what the risk level or acuity is. Yeah. So there's certainly a different cadence than in the I'm going to focus my entire world on a office visit. It's a different type of process today.
40. Yeah, and when you really look about healthcare in general and just the sustainability of healthcare financially and what have you, which is a whole challenge on its own, are EMRs actually helping to healthcare organizations to remain sustainable, to continue to earn the right to be in business, so to speak, right? And I would argue probably not the way they have been designed so far and where we're going. And what I mean by that is, as we move more into value-based care, we want to focus more about the patient's or the person's health over a longer period of time, over the lifetime of that patient, to be honest with you. So it's really not good when the record moves into different places, and when you have multiple copies of the record. If you as a patient, you go to different healthcare providers, and let's say there's no exchange, which is our next topic, of information. But then also, can the EMR transform itself? Can it be transformed to take on an education component, educating the patients more, providing the doctor with just-in-time knowledge to foster a more meaningful conversation, a dialogue with the patient during the point of care, and not even be so much right now treatment focused, but also thinking population, also being aware during the point of care, being aware of, here are my numbers, here are the numbers of the community, here are the numbers to the healthcare organization. And as a physician, I'm taking on responsibility, I'm taking on ownership of the financial burden, the financial outcome, the educational burden, and then the patient outcome thereafter, And so I wonder if the EMR needs to completely be rethought in its core, right? So maybe there's the billing component of it, the claims component, and you break that out, and maybe that's some kind of automated system behind the scenes. But then maybe there's a portion where the medical record becomes more a patient profile, a profile that stays with you, just like a social media profile on Facebook. You have one profile on any of these social media platforms, and that doesn't change. You maintain that, right? And so maybe the future EMR becomes more something that is a profile type of system, and doctors can interact with that profile, right? And thus somewhat enabling the community to then even start interacting with each other. So really EMR, I call it 4.0, right? 40. Do we still need an EMR? What do you think? Do we still need the traditional EMR where we're about to go in terms of population health management and value-based care?
Well, I think you bring up a very good point in terms of a patient profile, or a digital DNA, or a digital profile of a patient. When you think about all of the data that's collected over a lifespan of a patient, right. Some of that data is relevant, some of that data is not relevant, and it's never presented to a physician in a way that it's useful. Is the cholesterol test that I took 3 years ago relevant, or is it the one that I took last week when I broke my arm when I was 5? Is that relevant, or is it when I broke my foot 2 weeks ago? So an AI and more robust clinical information could then take all of that data and discern whether or not it belongs in my profile. Is it going to be relevant to build a digital image of what I am? And on top of it, and once I have a digital image of who I am, there may be gaps. And then going back to value-based care, what are those additional intervention, additional diagnostic tests that would help close those gaps based upon any health risks that would bubble to the surface after my digital profile has been created. Mm-hmm. And that's different than just an EHR that's going to house records. This becomes something that is a digital profile that becomes actionable versus something that is just staring me in the face and requiring me to take an action.
Yeah, I like where you're taking this. So maybe we can, instead of actionable, we say alive. I think a profile needs to be alive. It's a living, breathing document, so to speak, a profile that matures over time as you as a person, mature as well, right? And I think you were focusing on care gaps and things like this, which I think is great because the profile might show gaps and what have you. But I think once you have a profile that on its own starts engaging with the community, with specialists, with the provider, what have you, and you basically the profile itself becomes a hub for others to provide guidance and support, right? I mean, especially when you talk about cancer type of patients, they usually have a support system. Mental health patients, they have a support system. They put themselves out there on these kind of things, and people start interacting with them. And why not making this type of thinking available on top of the traditional EMR and saying, okay, we have this profile that stays with you, right, for your lifetime as a person, and whoever you interact with will also interact with your profile. And then whoever looks at your profile, they can then have a very comprehensive snapshot of your health journey, right, where you've been, and how does this even correlate with other profiles out there. And I think that kind of knowledge goes back to population health studies, right? For organizations to know the risk that they're managing in the communities, the risk that they're taking on in terms of, payment commitments and what have you, whether it's Medicare or whether it's bundled payment solutions and these kind of things, but to really start being not so much worried about not being able to manage the risk. And how do you really enable that? Through a comprehensive, secure, accessible profile that can be shared with other organizations. And so the next topic, which brings us to the next topic, which is 40 interoperability and data blocking, right? And so when you have a profile, when you have, or even in the current EMR, when you have your medical record, or you have multiple medical records out there, how do you traditionally ensure that if you move to a different county, you move to a different state, how does your new doctor get that information, or a specialist needs to get that information? But explain where we are right now, and then what's your thought about the future, where this could be? What could this mechanism of interoperability and medical exchange, what could that look like potentially?
Well, Oliver, I think that you hit the nail on the head when you were talking about what the new EHR should be, when you said that the community needs to work together. And so it's a crowdsourcing event that brings that profile together. And that crowdsourcing event is data sharing.
Yeah.
And that data sharing needs to happen in a way where everybody is free to share it. So the whole idea of the 21st Century Cures Act was to address an issue that was lingering, ever since everybody got their EHR and was paid to get their EHR. But now what? We all have our EHRs, but we're not sharing data. We still have a fractured system with about 800 different EHRs which are out there. And so to promote this crowdsourcing, we need to be able to have that data shared. And in order to have that data shared, it then goes back to the EHR challenges again, because many of these EHRs were built with old terminologies, and in order to use the FHIR standards appropriately, you need to have normalized terminology. And so when I've seen Epic or Cerner get upgraded at a hospital to be FHIR compliant, most of the 6 to 9 months that's spent doing that is normalizing terminology.
Yeah.
And so I think that normalizing the terminology will help with the crowdsourcing. I think we're very close to being able to share that data, and then at the same time, maybe even allow the patient to have more control in how that data is utilized. And then to your point earlier, in cancer care, it shocked me that only 5% of the cancer cases have actual staging information, because providers don't usually spend the time doing that. But if you're able to consolidate the clinical notes, the pathology results, apply some NLP or AI to it, well, now you're truly taking that consolidated data and from it making new derived data that can be very helpful.
Yeah. 40. Do you think that FHIR is the end state? I mean, I remember back in the days, it started out with UDP, TCP type of transfers. Then it was XML, right? Then it was CDA, CCD, and open medical exchange that we developed it into it, Quicken Health, and now it's FHIR. It's been out for a few years. It took quite some time for the industry, for the developers to actually start jumping on that. But do you think that's the end state, or it's just another state in the evolution of interoperability?
Great question. I think FHIR solves the problem of categorizing and organizing the data. I believe it does it in a great way at the atomic level. However, at the same time, the same challenges exist as they do with any integration, and that has to do with workflow. At what point are these transactions triggered? When a system acquires these transactions, which piece of data is more relevant or more recent than another? Yeah. And then it goes back to the normalization of the terminology, so everybody is speaking in the right language. Right. But FHIR allows for the integration of a terminology service. However, when I talk to a lot of people who have implemented FHIR, they do not know about a terminology server and how that works, and using that to be a way on how we can share data and not worry about the terminology. But going back, I think it's about the workflow, okay, and how that is done, which I don't think is a monumental challenge. I think is that if there's a way to make sure that the workflow is flexible and have the terminology take care of itself, it just might work. It may not be perfect, but I think it's the 80-20 rule. Okay. 40. One thing I've learned in my many years in technology is there's always an importance around one single version of the truth, right? And so going back to the like 800 some, EHRs, EMRs out there, and you start interchanging, transferring data, patient data, who owns the profile again, going back to the single version of the truth, which in my view should be owned by the patient. It belongs to the person. It doesn't belong necessarily to the healthcare organization. But how do we deal with the single version of the truth? And you brought up, the atoms and things like this, and you want to be asset compliant. That's a technical term here, and you want to make sure that you don't overwrite something that maybe was just entered and these kind of things. So how can organizations count on when information is being exchanged, is being moved somewhere else? How do they retain the version of the truth? And to be more specific, let's say I'm Clinic A and I'm sending all of us patient information to Clinic B. Clinic B is treating Oliver. Clinic A doesn't get anything back.
And then Clinic A doesn't get any updated information back today, right? Based on what Clinic B just did to me. And now if I go back, maybe at some point, maybe I hibernate in Florida during the winter times and I go back to Wisconsin and go to Clinic A, they don't even know that I was just in Clinic B in Florida, right? They know it from the billing stuff, maybe. If it goes through the insurance, the payer probably knows. But I don't think the EMRs, the EHRs know today. What's your thought on that, on the single version of the truth?
That's a great question. And sometimes the EHR in Clinic A doesn't know how to match Oliver in their system to Oliver in the EHR in Clinic B.
Yeah.
And then along with the idea of what's the single source of truth, who is the main steward of the data to ensure that that happens? Can it be the patient? Should it be the patient? Does it fall onto organizations like HIEs? Does it fall onto, and this is going back to the crowdsourcing that we're talking about, is it done with, and hate to add additional dimensions to the discussion, but is it something that possibly blockchain should be a part of? And so then you have blockchain being part of the stewardship, and then this way you could say, well, trust doesn't reside in any one of the 10 EHRs that are used by the 10 providers which may be involved in my care team. It may exist in a blockchain, type of scenario. Now,
HIE blockchain.
Exactly.
Yeah.
And I think, and whenever I bring up the topic of blockchain and healthcare information technology, people look at me very strangely and say, well, blockchain is just a buzzword, just like AI. And how does that really work? But when one takes a look at all the blockchain and healthcare information technology projects that the Mayo Clinic has done, not only have they put data into blockchains, but they also have had AI algorithms run in concert with that information.
Yeah.
And then at the same time, not just taking information that from the EHRs to determine a single source of truth of a data, but there are EMPIs today that go beyond and bring into play public records in cooperation with the data, so that one could be 100% certain that a person is a person is a person, and then have logic to get to the right record. And then for a patient, most patients aren't really engaged in their health until they need to be. And sometimes the number one problem they have is not consolidating their data, but getting an appointment earlier than 4 months away. So, but to your point, I think that there's something there in terms of how do we get to a single point of truth that is not just pointing at any one EHR, but pointing at a repository that has some level of stewardship around it.
Yeah. I think you're right on it. I think that's the next step. I think the biggest problem that I see, and based on my experiences, is the single version of the truth. It's just not there. It's a huge problem for patient health, in like long-term health, because let's face it, Americans move a lot. Every time they start a new job, it's usually somewhere else, and then they move a lot. So people just constantly move. So they switch doctors, a few times in their professional lives, and these records are all over the place. So nobody has a comprehensive view of where you've been in terms of your health journey, right? And good luck trying to remember where you've been. I mean, I don't even know where I was 10 years ago in terms of my health. Like, who did I see for what, right? I really don't remember. And so I think blockchain, as you just put it, could potentially be the HIE of the future. And the wonderful thing about blockchain is nobody really owns it. It's truly owned by the patient, right? It's totally secured, and only you can access it, and you can give permission to other, healthcare outfits to access your information. And you could potentially even break it down. How much can you access? I'm only going to allow you to access the past 24 months or the past 24 years. It's really entirely up to the patient to kind of choose that, right? Just like how many bitcoins or fractional bitcoins I want to move out now somewhere else, right? And there's like 1, 2, 3, all of them, right? And so I think the same thing could potentially be true for my healthcare record, Fortium. And I really think when we start looking at value-based care, the past of EMRs to traditional EMRs, which I think they already got the kiss of death many, many years ago, which just still depend on this glorified billing thing because of the fee-for-service apparatus itself. It's just, the primary apparatus of fee-for-service, as you know, Louis, is getting paid, right? It's about billing. But as we are transitioning to taking on more risks and managing high-risk populations and turning this into a revenue model that also provides healthy population that actually produces healthier populations. Because let's face it, Americans in general, the American population is sick, and something just needs to happen. Fundamentally, something needs to change. And fee-for-service clearly has failed in doing so. They just don't do that. They're episode-based. They're just fix stuff. And we don't need just fixing. We need to have an involvement in our health. We need to be invested in our health. We need to truly feel that we're in charge. And everything we do to ourselves in regards to our health needs to be traceable and forever, and it needs to be immutable. You can't delete it, right? And you can delete it, but nobody else, right? And so blockchain to me provides a superb mechanism to do this. And I really hope that somebody is listening to this, maybe some innovators, some startups, and saying, you know what, I'm going to develop this blockchain HIE, and I'm going to provide interoperability to all these 800 EMRs that are out there. And I make it easy to move data back and forth, right? And then give full access to the patient to manage their blockchain, to manage their profile, right? So maybe it's an HIE blockchain profile if we put all the words together now. And once you have this profile, HIE system out there, maybe we actually have provided an opportunity for the doctors to start educating every person. And then that educational component resides within the blockchain. So it's always accessible to the patient. And at any time thereafter, they could always reference back, what did I talk with Dr. X, Y, and Z about? This is what he or she recommended. And it's clearly always there. Versus these, I think there was a meaningful use requirement to hand out visit summaries, right? And when I get these visit summaries, it's printed out. And what do I do with it? It just goes away, right? I mean, I look at it once and then it goes. I don't even have a folder, a binder where I put my clinical summaries because I don't go to the doctor that often. But it would be nice to look at my clinical summary from 5, 6, 7 years ago, but I can't do that today. I don't have that piece of paper anymore, And so I love that. Anything you want to add in terms of like that whole idea about an HIE blockchain profile? Do you think that's something that the market could potentially be excited about? Do you think it actually makes sense for patients themselves to kind of start having that kind of control?
Well, I think so. And I think that we touched upon that on the interoperability discussion, and certainly tying that back into the education discussion and then linking that into outcomes. I mean, the whole idea of helping to eliminate information blocking was not just to share data, but to share data for the purpose of innovation. So, part of the 21st Century Cures Act has a lot to do with also things related to, drug research, research to helping children.
Yeah.
So when you tie that back to value-based care and wanting to get the best outcomes for the least amount of cost, and you have all of this data together and you have all of these learnings, you start to develop best practices and ways to decrease the variability of care, and then at the same time making it a repository that could also be leveraged if I, as a patient, should want to, maybe participate in some innovative studies, maybe help to advanced healthcare. I know I'm going maybe a little bit off topic, but I think it
not at all
to the heart of outcomes. But
Fortium.
The biggest issue is recruiting patients for these clinical trials or studies to improve medicine.
Yeah.
And if you have all of this data in a blockchain, well, you could say that maybe I want to vote to be part of the clinical registry part of the blockchain, and take advantage of those new innovative care measures. But and at the same time, that certainly is maybe after the fact of just ensuring that the best practices are in place and shared.
Yeah.
Because every different ACO that takes on a value-based care contract, they use their own mechanisms. They decide what their programs are going to be, that they implement in order to get to the point where they're able to get the right outcomes and be profitable and get the best care for their patients. And the number one issue, having spent a long time with population health systems, the number one issue in implementing any sort of ACO system, any sort of population health, was always data acquisition. It was 95% of getting everything up and running. But if that exists, in a normalized form, and there is, in addition to all of the clinical data, but I could have my history of coverage eligibility, life becomes a whole lot easier, because the same problems are being solved by thousands of different organizations over and over again. But having it in one place with one stewardship methodology would certainly have a stronger impact sooner, would certainly decrease the cost of care, because having tens of thousands of people do the same thing over and over again with different forms of the data doesn't exactly seem like the most efficient process.
Yeah, I like where you're taking this whole thing like a full loop. Yeah, you're bringing it all the way around, like you just talked about life sciences and everything, and clinical studies, and really start using that profile, that blockchain, that whole data to not just be immediate care activated, but else all the data that goes in there, it should participate in providing life sciences, in research and what have you, for the benefit of every person thereafter. Because if we are community focused, if we start reconditioning ourselves as human beings and saying, my health is just as important to me as the community health, everyone else, right? If we start having this type of attitude, and it doesn't really hurt me to change the data, and there's no effort on my part, I just have to agree that, yes, you can use my data for these type of researchers out there. Now you enable provider life sciences, what have you, to start innovating and providing better treatment options, medications, and treatment paths, and all sorts of things, and make that available in turn back to me, right? Which is, I think, tremendous. And this really gets us to the last topic, which is, 40 artificial intelligence. And a huge component, my work at IBM Watson Health had a lot to do with finding pathways to infuse AI, Watson in that example, into the care apparatus, and start enabling AI to learn from the interactions between the patient, the provider, the clinical care apparatus, and the patients themselves. Really start learning from that. And this directly reflects what you just talked about, which is, hey, let's start using that information that's in the blockchain, that's available, and learning from it, and then feeding it back to start making something better. This essentially is what AI, in my view, was meant to do, right? AI is not like, necessarily machine learning, deep learning, or advanced analytics. AI, the true AI part for it is, in my view, is where the systems have a mechanism to learn from everybody that participates, especially when you have a blockchain type of HIE and everything goes in there. Now, artificial intelligence, some deep learning mechanisms can get really smart on certain treatment paths, what's successful, what's not successful, and then, start building a comprehensive, a knowledge of what works, what doesn't work, especially for what populations, for what person, if you want to be more specific, drug outcomes and all sorts of things, but then making that information available as an educational component back not only to the profile, where now the patients can somewhat be, educated again. Hey, by the way, we just found out that if you just do this a little bit more often, you have these type of benefits, right? But then also during the point of care, whether it's telehealth or it's an actual, in-person, patient room encounter, but playing that knowledge back to the, primary care provider, to the specialist and what have you out there, to make more informed decisions, right? And with every decision that's being made, again, going back to your architecture of loop it back, every decision that's being made, there's cognitive feedback that helps AI to get smarter and smarter and smarter, right? And so that's the way I look at this today. And I was wondering, what are your thoughts in terms of AI? Everybody's talking about this, but how do we decorate the current, healthcare technology cake, so to speak, with AI? Or if we can't do that, where should AI really be in terms of healthcare?
Oliver, thank you, because I appreciate the path that you went through in this discussion to bring it to blockchain and data, and then bringing it to AI. And I think in order for AI to work well, you need massive amounts of data for it to work on, and not just a lot of data, but also well-represented data. So,
you mean contextualized data, right?
Yes, and also data representing health equities. I think that it's very important to have data that represents everybody, because that's how healthcare or smart healthcare needs to be delivered. Especially living in a world that's about to enter the age of digiceuticals, where I'm prescribing not just medications, but I'm prescribing apps, and the value of those apps are based upon the depth and breadth of the data. And when it comes to AI and machine learning, the value will be in amassing the data. So if there's a mechanism in which it's easy to amass the data and then apply algorithms, I mean, there may be great ways where having information in a blockchain, whereas maybe I, as a patient, want to say, have my information available, de-identified, so people can just do work on my data, and have it be part of the AI logic. And then, to your point, being able to show something back to the provider that gives the provider a leg up. I mean, I don't know how it's possible to be a physician today, whereas you have an order of magnitude more medications or interventions now than it was 20 years ago, or a different granularity of diagnosis and so many different methods of care or pathways. I don't know how that is even possible. And now you combine that with a shortage of physicians, a growing need for more complex care for elder Americans. I think AI and having that targeted is the only way. So I could not agree more.
40. So you just said something really interesting, and I haven't heard that before. You were talking about, and correct me if I'm wrong, but prescribing apps, so to speak. So can you elaborate, like what kind of apps? And because the first time I'm hearing this, and I'm absolutely fascinated by that.
Well, when you think about it, if you combine the idea of information that exists with AI with biometric or location-oriented information that exists for a patient, their current conditions, and then allow the physician or individuals who are nurse practitioners or physician assistants, if you allow them to intervene at moments that make sense, I think that having somebody be prescribed an app may be better. It may be something that, for instance, pre-op and post-op for an operation. And I think the statistics are that if I do exercises before I go in for a surgery, and I do them after the surgery, the outcomes will be better. If I'm able to detect stress or craving, and I'm recovering from addiction or substance use disorder, well, then that's going to help me eliminate at least 6 months of therapy and hone in right on the coping skills, and not look for medication as the answer, and listening to the FDA talk a lot about it. That only works if you have all of the amassed data. You're using AI, and even the FDA is saying, well, you just can't use AI. You have to let us know the amount of data you're using. How are you using it? When you think about when you're going to take a medication, you look on the side of the bottle, and it usually has its black box warnings. Before you use an app, you want to know the parameters of it. But it's happening. It's happening today, and I think it will be happening more and more, and driving more of the quick intervention approaches as opposed to protracted telemedicine or office visits.
I'm just fascinated by the idea of the doctor subscribing an app to somebody. And I think it would probably, I would guess, it would work superbly for the younger generations. They're constantly looking on the phone anyway, hands down. Subscribing an app for take care of yourself, buddy. Work out, and you're gonna gamify it. You do track it. It's standardized, right? And it feeds right back into the HIE, into your blockchain, component, whatever it is. But wow, I mean, I think that's a great idea, because I think there's actually a generational divide a little bit between, physicians and then the younger generations, and then they have a hard time communicating, right? But you kind of don't want to get too much off track. But I think subscribing an app to start engaging you and activating you as a patient, and then in younger ages already start being involved in your health, in your well-being, using an app, which is a very natural thing for them to do anyway, and they might even get rewarded for doing so. But then now you are conditioning them in a way to participate actively in their health and actively remaining engaged with their primary care physician, which is so important, right? That's a relationship that you go back many, many years. I mean, the medicine man was sort of in the house doctor, the family doctor, that's been there forever. And for some reason, we kind of stopped doing that, but it had huge benefits back then, right? And so even prior research shows that had huge benefits to the overall well-being of not just a single person, but the whole family. Sometimes to even, an entire village. There was a village doctor, right? And it kind of took care of things. And
absolutely.
Yeah. So we completely missed that, right? And I think maybe an app can do that again. I mean, why do all of these people connect on social media apps? Because it's a community, and they call it communities. Even Facebook calls it communities, and Twitter and these kind of things. And there's something sad about it. So maybe we can take, what you just talked about and kind of turn the negative, connotations with, apps and social media, turn it into something more positive when it becomes official, it's being prescribed. We want you to use it, but it's really an educational component and community education component around every person's health. And I think that, to me, goes back to the original topic of the essence of value-based care, right? And it's really, value is the key word here, right? And it's not so much, the financial component to institutions has a lot to do with it today. And a lot of it started with that, to take on more risk and be responsible, as a physician to start taking on, be accountable for the outcome, so to speak. But I think that's just scratching the surface. I think if you really do a good job in terms of value-based care, this is a generational type of benefit that is community inclusive. And so these kind of ideas that you and I just brainstormed about, and especially what you mentioned about prescribing apps and everything, to me, that warrants a lot of discussions out there. And hopefully some of the, healthcare innovators and entrepreneurs are listening right now, and maybe to give it a shot. I would definitely do it. It's this whole blockchain thing, AI, prescribing apps, the next version of EMRs, and really start leaving behind some of the traditional views on what an EHR actually was supposed to do versus what it actually ought to be doing now, to enable our doctors to actually enjoy themselves a little bit more during work, which is also important. It's very important. Unhappy doctors don't produce happy patients. You need happy doctors too. So
absolutely,
yeah, I love it. Louis, do you want to add anything to this conversation you and I had?
Well, I've thoroughly enjoyed this discussion, Oliver. As I said earlier, I think the flow of going from the EHR to value-based care, and then coming back to a crowdsourcing community, and leveraging the existing data with AI is is great. So I really appreciate how you've organized this discussion and the thinking. And to your comment earlier, I think everything we discussed is probably something that could launch at least 50 startups.
That's right.
And I'm sure there's a lot of people in the space today that are that have been entrepreneurs and early adopters of everything that we just spoke about. The future is certainly bright for all of this technology to take hold. So glad we live in these interesting times.
It is interesting. Louis, I really want to thank you for your time. And for everyone else out there, we are the guys from 40 Partners, 40partners.com. That's where you find us and more conversations on the particular topic. It's really important to talk about innovation, talk about digital transformation in healthcare. This is what I do. This is what Louis is doing. This is what we do. This is what we eat for breakfast. This is what we eat for lunch and dinner. So go ahead and carry the dialogue, carry it forward, and don't forget to reach out to us anytime you need us to rock the boat a little bit in terms of healthcare and your digital transformation. See you later.